handsome because he's such a philosophy. We've got two very exciting talks today, and we're going to be starting off with the solution-focused approach, practice-based evidence of child-centered care. So today the whole theme is all about the child that we love to look after. And I'm going to introduce Jane Booth and Christian van Wilden, and we really look forward to your talk. Thank you very much.
Thank you very much. Good morning, everyone. My name is Christian van Wilden. I have been a medical officer in this hospital for the past 2 years, and I'm really happy to join this presentation together with Sister Jane Booth and Nokutula Johnny. Thank you for being here. On the 16th of April 2014, I came to Cape Town, and on the 17th of April, I joined a lecture with Prof. Louis Reynolds. And afterwards we had a chat and coffee, and I told him I just attended a course in solution-focused brief therapy, and he asked me what it means. And I explained to him, and then he said, "You must meet Sister Jane Booth, because that's what she's doing." So I'm excited to be here together. Before we start off, let's say it will be a bit of a co-creative dialogue, if I may say so. But before we start off, suppose this will be a useful lecture. We were wondering what could happen or what could we discuss with you so that if you leave, say 9 o'clock, this lecture hall, you feel that it was actually worthwhile visiting. Or in other words, when you walked up the stairs, entering the room, finding your place, what were you hoping for? We thought it would be very useful to give you some practical insights in how we use the solution-focused approach. So I think it would be nice to start off with a certain background. Please, Jane.
So I think most of you here know me. I look after the tracheostomy and ventilation home care at Red Cross Hospital. This is, I will be retiring this year, but this is 30 years of tracheostomy and ventilation home care at this hospital. We started small, but we're now quite well established. And we just go back to the old adages when we think about our practice. And we think about the primary health care approach that spells out that people have the right and duty to participate individually and collectively in the planning and implementation of their own health care. It requires the action of many other economic and health sectors. It needs to be sustainable, using available and accessible technology. It should not be expensive. And so at a tertiary hospital, our responsibility is empowering mothers and other members of the family with knowledge, skills, equipment within a well-functioning support structure. So we have a marvelous multidisciplinary team, and in that team you'll see one of the orange ones says nurses, and I'm one of the nurses on that team. I'm the advanced practice nurse and based in E1. And then, thank you, Diane Gray, for this lovely slide, just to show you what our load looks like. The blue lines are the new patients, or the patients who start at the beginning of every year. Those are the patients that we start with. The red line is the number of tracheostomies, and the green line is the number of patients who are ventilated. So more and more we're getting mask-assisted ventilation because we're able to prevent the children from going to ICU and having tracheostomies. But you can see that there's sustained growth in our service. So what is the nurse practitioner's work? It's exclusively moving others, moving people to get things done, assessing, evaluating, planning, and establishing care throughout the continuum of care, from before the patient gets the trachea and right through to the intersectoral approach. We case manage every single patient individually. So I'm very happy to say that one of our patients' parents, Nokutula Joey, is with us, and I think Christian will introduce her to us, and we're going to ask her how her experience has been with all of us, because she didn't come originally from us, but she is now in our service.
Nokutula, you came to Somerset Hospital and then to Red Cross Hospital very soon after the birth of your son, later. Can you tell us how was that first week for you? Because it was actually before you met the nurses in E1, wasn't it?
Yes, it does. Greetings out at large. My name is Nokutula Joy, the parent of Oletu Joy. We arrived at Red Cross on the 29th of January. Oletu had some problems with breathing. So we transferred from Somerset to Red Cross, and the baby was in ICU for some time. For 2 weeks, there was respiratory distress, so that's when the doctors decided now they need to do something, otherwise we're going to lose the baby.
So, how was that discussed with you?
Okay, some PhD doctor came and explained the whole treatment process to me and said I need to go to E1 to get some counseling as well, some information about the trachea and the training organs. And they introduced me to Sister Primrose. So I went to Sister Primrose. Sister Primrose went through with me. First we did profile. She asked about myself, my family, and my background before we did the whole counseling. We did the counseling, we did the orientation, where I went to see other parents with baby with 3 years to me.
So how was that? Because I suppose you never thought of trachea in your life, or?
I was very scared and reluctant about the whole process, so I said, no, let me not be selfish, because I can see that my son is suffering, so I needed to do something. So after I saw all the parents with babies with trachea and how they were happy, so I said, if they can do it, so do I.
What other experience did you have prior coming through the hospital that made you feel confident that you would actually be able to do it?
All right, so I had an ex-colleague of mine who I used to work with. She had a baby with trachea, but now she's trachea-free. So during lunch break, some other time, it was I think 2 years ago, she told us a story about her baby and her genital trachea, and we all knew nothing about the trachea. So every time she used to tell us, we used to cry. So that's why I was scared. Oh my God, is this really happening to me now? Because I knew about the trachea before my son needed the trachea. So I didn't have information about it.
And then it happened.
And then it happened.
And how was that after?
At least he was fine. He was very normal. He was like normal baby now after the trachea. So we went to E1 after 7 days from ICU. Then we started with the training.
And how do they teach that?
Okay, the training, Sister Primrose, she was the trainer with me. So she, for the first 3 days, she did it by herself. She showed me how to do it. So I think on the 4th day, I was comfortable to stay. So I was comfortable. So okay, it was weekend. So Sister Primrose was not there. So I told one of the nurses, okay, it's fine, I'll do it myself, but she just needs to be there to observe. If ever maybe I get stuck, so that she can be able to assist me with me. So I changed myself, and I was proud.
Wow.
Because it took me only 3 days.
Yeah.
So, yes, that was very good. So when they came on Monday, I didn't ask Sister Primrose, Sister Alice, I just did it myself. And when they came to me, are you done? I was like, yes, I'm done. And so, yeah, because I was very eager to learn and I wanted to go home. So I said to myself, I'm going to spend 2 months here with the training, so I just need to be comfortable and then confident.
I heard that the international standard for children with a tracheostomy to go home, it takes about 3 months on average. You told me yesterday that you were ready after 3 weeks to go home.
Yes.
And how were you so confident that it was going to work?
I was. Even in the first week, I was sure of my story. So it came the second week, I was doing the things already. Third week, I was a meaningless.
So how do Sister Primrose and Sister Jane help you in that?
They were there all the time, willing to answer all the questions, willing to teach. So they made sure that I was 100% comfortable before going home. Because remember, at home, there's no lessons, you by yourself. So you need to be sure that you know everything before going home.
And how else did they help you to become confident?
They were there to teach. They made sure that I knew everything. I knew what to do in case of emergency. I knew how to take care of my baby at home. So they were giving the support all the time. They made sure that you understand each and everything before you go.
When you just came to meet the nurses on the ward, I think you said the word profiling. They asked you a lot about your family,
Yes.
about your house, where you live, where you work, what you studied. Is that something that is part of the process, actually? Is that something that is important?
Yes, so I think it's terribly important to get to know your families and to understand where they come from, so that you're able to teach them and understand where they actually come from in the beginning. And sort of in the beginning you feel as though you're holding their hand, and slowly but surely you're able to let go and they're able to manage all of that. And I'm particularly proud of Nokutula because she's learned how to look after the tracheostomy and the gastrostomy, and she's been able to help other parents. So just this morning, before she came to this meeting, some young student nurses came up from another ward to learn to change trachees, and Nokutula gave them a lesson on how to change the tracheostomy. So this picture here is just a beautiful picture and of two people on one of these penny cycles, and it's about how we attune ourselves with our patients. So you imagine that wibbly wobbly cycle that you're on. You need to hold hands so that you can balance. But look at them looking into the distance together at what the future holds. And that is how I believe we need to be able to help our patients by knowing and understanding in depth their situation, so that we can walk that long road with them through our care.
So back to the solution-focused approach, because let's say, what does it mean? These two people, Steve the Chaser and his wife Inzuki Burke, they were systemic family therapists in Milwaukee, Chicago. In the 1980s, they were working with families with problems, and they realized after some time, no matter how hard we try to understand the root cause of the problems that these families have, we don't get any further, and yet the suffering goes on. So as an experiment, so to say, they asked these families to tell them how life would look like when the problems would be over. And to their nice surprise, they realized that these families were capable of telling nice stories about how life would be different. And in the course of the treatment, families would be able to propel themselves towards that, what they call preferred future. So being solution focused, it's not about trying to create a solution only, because we're all interested in solutions. It's not different. But this solution focused approach literally means that you think of the situation, or you position yourself in the situation when things are different and how it will look like. For me, it is a nice add-on approach to my medical approach. Because in the medical approach, I usually try to define the problem in find a diagnosis in order to provide a treatment. In lay terms, you know what you're suffering from, you know what you don't want, and that's why you go to the doctor. The solution-focused approach helps me to find out what does the patient, the parent, mother want instead. So you get stories about context. Let me give you a small example. It's not my example. I was teaching this a little bit to a colleague, and then he tried it out in his asthma clinic. He had a boy in the clinic, 10 years old, with difficult asthma. The asthma wasn't that difficult in itself, but the boy had difficulty taking the treatment. And so my colleague tried this slightly different approach, and he asked the boy, suppose all the problems that we have been discussing, considering your asthma and the asthma scores and the pumps and the diaries, and that's over. What would be the first thing that you would notice? And then the boy said, I would belong to my friends again. And my colleague asked him, what do you actually mean? And then the boy said, my friends would knock on my door in the morning and ask if I would join them cycling to school. So cycling to school, being active, physically active, and joining a group of friends is apparently important for that boy. It gives a context that can help to incorporate treatment maybe in his life in that way. And that helps me as well to understand how my treatment, my evidence-based treatment, fits better with the life of the child.
So just to talk a little bit about the solution-focused approach in our context here on this tracheostomy and ventilation home care program over the last 30 years. During the initial medical interview, the two most important qualities that parents expect from a nurse practitioner are sincerity and a glimmer of hope, regardless of the seriousness of their child's condition. Similarly, when there's no hope, no matter how small, the family can motivate internal forces in order to face the difficult new reality. We need to discover the skills, the strength, the qualities and beliefs that are used for this family in their capacity. So we also need to understand other things around the family, their relationship with their partners, their other family, friends, faith, community and work. And I think we've all done this in our history taking, but it's following it through with action and training of the mum. So once we've finished our training and the mum feels confident, trust is a leadership competency, but it's not based on character alone. It is essential to be able to place responsibility with someone and then trust them to do it. So once we've trained our mums, we have to feel confident and be able to hand over that responsibility and then trust them to be able to carry it forward. And this is part of the absolute core of the primary healthcare approach. So it's not something new. So we have many acknowledgements, but I think that you all know that I'm retiring soon, and I think that it's been very nicely described in the succession plan that Sister Primrose will be taking over from me. She's in the room here today in the second row, and how competent she is at being able to manage cases of children who have tracheostomies and ventilation for home care. So now it would be very nice if we had a little bit of interaction with the audience. We've still got 10 minutes. And just, to be able to help answer your questions and maybe think about ways of managing, especially in very high urgency sort of situations. People often think, well, how am I going to do this in outpatients? With the coughs and the colds. But our hospital is full with children with chronic illness. think that that's where the success of the tracheostomy and ventilation home care has been, and the fact that we've been able to discharge children who are technology dependent. And technology dependent means that without that technology they will die. So they need a technically skilled carer to take them home. And that's why the program's been successful, because one person has taken them through the circle of care. Yes, there's ward staff there, there's a whole team of people around you as well, but there's always the one person who's taken you through from beginning to end. And it's not this sort of service that's, falling apart.
Can I just ask Sister Primrose to stand up so that people know who she is? She's a very lovely lady. It's always nice to put a face to the name. Thank you. Right, lots.
We are all time pressured, and this clearly takes time. So can you give us some insights into the best use of time in terms of a consultation that gets you quickly the kind of change of thinking, which is what you're describing, that comes out of the solution-focused approach?
You're right, you need time. However, I feel that starting off in the solution-focused mindset helps to activate the patient as an expert in his own or her own life, as much as I'm the expert in the medical field. If I do it the other way, I start with the medical approach, and then if there's time left, I do a bit of solution-focused. We are already in the default that I'm the one that is going to solve the problem, because that's what is on my plate. And funny enough, even though you ask for the preferred future, you get the problems for free as well. So it makes my life, my work also much nicer. But it's not always possible, and sometimes you have to cut corners, at least try to be quick. But then it helps me to think I can do bits, and we can come back to the bits later.
I think it's important to take that continuity connection and to say we're not going to solve it in this first consultation. That trust element, people will then come back, or you put them in touch in terms of whoever else they need to see, in terms of money getting back or whatever, which is that at least you've got a plan and you open the door, which you described very, very nicely.
And small changes can lead to something else. So within the period that people will not visit you and come back, things may have changed.
And I just think that, for instance, I've got a couple of very busy clinics where, it's a high turnover of patients that come in. So they have experienced this whole ward situation. But when they come to the clinic, even while I'm just washing my hands, and I'm asking, how's it been going? I haven't seen you for 2 weeks or a month. What's been happening? This expert parent is able quickly to explain what's been happening. She's worried about the feed, or there's been some change in the family. If you start off with a good foundation, you're able to be pretty quick in going through the long-term care.
Lori?
I'm just interested to listen to your story and how it focuses so much on heart and on relational skills. The attunement you talked about, trust you talked about, appreciation and recognition of the strengths that both children and parents bring with them into their encounters with the healthcare system. And when we talk about the transformation of our society, of our healthcare system, of our medical education, my sense is this is what is at the heart of it. And it's shifting the power relationship, it's recognizing the expertise that exists also within the family. It's bringing into alignment health professionals and caregivers and bringing it into evidence-based, but also in the nurturing care framework that is underpinning the approach to the first 1,000 days. And I would just encourage us as a faculty to make sure that these qualities that you're speaking of are explicitly referred to in the qualities of the proposed qualities of the medical graduates leaving UCT. Because I think that is the solution. It's incredibly hard.
My warning would be, I don't mean it in an alarming way, but you may experience a little bit of vulnerability when you start a procedure. For example, when I asked you this morning, so what could be useful to discuss when you leave this audience, it would be useful for you. Then there may be something coming up that I can't provide. And then you may feel stuck. But then it's the challenge to continue and see, so what's actually at the core of the desire. And that takes a bit of time to find out. But it's also fun.
David?
Thanks for a really wonderful congratulations. So I think Jane's work really shows how actually, even from a specialized hospital, you can apply the primary health care approach. I think that's a really important lesson. Translating something quite complicated into a community or family-based solution using appropriate technology. And some of you may remember, just over a year ago, Professor Tony Costello giving a talk here on what he calls sympathy groups. So those of you who care to look at the literature published in the Lancet and other places, he's shown co-workers, first in Nepal, now in India, Malawi, and other places, just getting women together to talk about maternal and newborn problems as the only intervention, just getting them together, facilitated initially by a community health worker, has reduced newborn mortality in that group compared with the control group where there was no such intervention by 30%. So I think that showed, and these were very rigorous community trials published in the Lancet. So I think that's the same thing, but on a bigger scale, and that we should always, I think, bear in mind that patients, groups, people, community involvement is really a neglected area of healthcare, and sometimes it's impossible to just we need to drive that in our practice and our teaching.
Samir, a quick question, and then that's going to be the last one.
To echo what Jane said earlier about the profiling of patients, even in our physiotherapy service, we have our chronic long-term patients. It's important to establish that relationship with the family. We're able to get that trust and that rapport with the family so that we're on the same page. We can have our own clear medical goals for the patient, but the parents and the child have different goals, and we will never achieve anything. We will never be able to establish proper diabetic care or anything or aspect of growth if we're not on the same page. So building that trust with the family, building that relationship, and empowering the caregivers and the family around the child and to be active participants in the care of the child is important. We're only able to see a child once every 4 weeks, once every 6 weeks, or even longer, and they are custodians of that care in the time between when we see them. So being able to come up with solutions to pertinent problems is important for everyone.
I'm going to stop us there. It sounds like we need to have lots of discussions about this, but just one little anecdote is I went to a congress with Jane some years ago in Istanbul where she presented the work that was being done at Red Cross, and I was really proud of our team here and of our parents. When somebody from Great Ormond Street, now South Africans, we're always looking at the grass is greener overseas, and Red Ormond Street, this wonderful hospital. And I asked Jane, how long does it take you to work with a family and train them to be confident? And she said 6 weeks, sometimes 8 weeks, and she asked them, how long does it take you? And they said 1 year. Okay, so well done to this team, and lots of food for thoughts. Thank you very much. Introduce the next speaker, but before they come up, can I ask everybody just to move in? Because there are lots of people sitting on the stairs. There's nothing scary in the center of the lecture here. Okay, but please do work. There's a lot of seats down in the front and in the third row. Can you guys do anything?
I'm talking here on behalf of the Advocacy Committee, together with the Social Work Department. Within the Advocacy Committee, we have been talking about this problem, I think, for the last, at least the last 5 years. And really wanting to find a way to respond to what we are experiencing as a rising tide in the extent and the severity of violence against children. So this is, in a sense, an invitation to step up, to join us in taking action, as well as a recognition of the incredible work that is done here at Red Cross in holding a line and supporting both children and their families. So we know over the last 25 years at Red Cross we've seen an increase in the numbers, and if you look at the way that it's been spiking, particularly last year in 2018, and already here in 2019 we will have seen over 250 cases of violence against children. That's 50 cases a month. The burden on the social work department or the child protection team is relentless. And what we're seeing at the Children's Hospital is really just the tip of the iceberg. We know that nearly half of children will have experienced some form of violence. 1 in 3 will have experienced physical abuse. 1 in 3 will have experienced sexual abuse. 1 in 4 emotional abuse. And 1 in 5 neglect. 99% of children in Soweto and Johannesburg who formed part of the Birth to 20 cohort study have either experienced or witnessed violence. And South Africa's homicide rate is double that of the global average. So what we're experiencing essentially, as Tony's placard captures so well, we're experiencing a country that is at war with its children. At Red Cross, we see children who have been shot, beaten, burnt, neglected, sexually abused, with many of those children experiencing multiple forms of violence. We see children experiencing violence in their homes, in their schools, on the streets, in their playgrounds, the places where children should feel safe. And in many, if not most cases, the perpetrator is known to the child. And it's not only men. very often it is mothers who are carrying too much and who are desperately in need of support. We also know that violence is seldom random. The determinants of violence study identified a range of different factors that in a sense place incredible pressure on caregivers and families, and in many ways creates a very perfect storm. So the combination of violence, poverty, crime, substance abuse, impact on caregivers' mental health, and undermine their capacity to care and protect children. We also know that violence against children and violence against women share the same common risk factors, and they tend to co-occur in the same households. So when you see a woman with a bruised face, you need to just not be thinking about the woman, you need to be thinking about the children in her care. Because it's a red flag, it's a warning sign. Violence doesn't just affect girls, boys are equally at risk. And so when we look at the National Optimist study, we found that not only 1 in 3 girls experience sexual abuse, we saw the same rates of abuse experienced by boys. Only 1 in 3 of those children likely to ask for help, and boys far less likely than girls to speak out. We also know that infants and very young children are also at risk. These data come from the first 4.5 months here at Red Cross, and in some ways are skewed given our focus on younger children. So we also need to understand how the pattern of violence, the nature of violence shifts across the life course. So very early in infancy we see infanticide, abandonment, women who are simply not coping with young children, maybe women who didn't want to have them in the first place. And then a pattern of child abuse and physical abuse, sexual abuse running through from very early in infancy through the life course, with male-on-male interpersonal violence peaking in adolescence. We also know that the violence causes not just immediate but protracted harm. From fear and distress to poor self-esteem, inability to concentrate and learn at school. Very often it's externalized through aggression or risky sexual behavior, feeding into substance abuse, mental health problems, suicide, criminality. So what happens in childhood starts to spill out beyond the life of the immediate child and family and into the community. These effects can last a lifetime. We know that girls are more likely to internalize, to turn that violence in on themselves, to experience depression, anxiety, suicidality, whereas boys are more likely to express the violence outwards, to turn it out through aggression and violence. And we know that just witnessing domestic violence feeds into a cycle of violent relationships and violent caregiving. So what happens now is not just about this child's life. It starts to play out as an intergenerational cycle. So the question is, how do we make it stop? What is our role as health and allied professionals? The first thing is our duty to report cases of abuse and neglect. And the intent here is to protect the individual child from further harm, but also to make sure that we're protecting other children who may be at risk. Secondly is to deter perpetrators. And we have 2 pieces of legislation that have slightly different intents. So the Children's Act is designed to promote reporting so that we can link families up with support services. Whereas the Sexual Offences Act is primarily interested in prosecution, and it triggers a criminal justice response. And very often we get focused on the criminal justice response and both children and their families need. So very often, for example, where a child has been abused, that triggers the mother's experience of abuse and neglect. Perhaps Carla would like to share a case that speaks to those intergenerational effects.
I think when I hear Laurie speak, I just always want to look at the social work department and call them up, because they'll probably have a case to illustrate every aspect of what Laurie speaks about. But if I think of, so every week we have a number of cases, and I think to myself, after a number of years in this work, can you still be surprised? I look at Vuyo now and I think, Vuyo, can the two of us still be surprised by what comes before? And just this week, one of our social workers, Lazal, managed a case where one of the doctors from MOPD sent a case through. And I'm using this case as an illustration to just show you that what you see, and if you don't engage with the parent, you only really get what trauma sits on the surface. And I'm not saying that everyone in their clinic has got a responsibility and a role to uncover what is sitting at the bottom. That's probably sitting, unfortunately or fortunately, with the social work department. But what I am saying is you are saving more than just that child's life when you refer to the social work department and when we uncover what this child is actually experiencing. So a 6-year-old girl comes in through MOPD. She's referred from one of the community health services. She had blood on her panty and she had a greenish discharge. The claim being she fell on a rock. The doctor examines and the doctor finds no injuries on the labia minora majora, instead finds 2 notches at the 6 o'clock and the 10 o'clock position. So we do our interview, the doctor refers to us, we do our interview, and what we uncover is just a family in crisis. So definitely the distinct impression after, unfortunately, some vigorous interviewing with the child, we left with with a very high level of suspicion that she's been sexually assaulted, but she's not bringing out any of that. But when we delve into, like Jane says, when you look at the family and you look at the support system that needs to hold this little girl of 6 years old after she has, like Rowan Dunkley told us in our child protection meeting on Tuesday, she's most likely, unfortunately, been raped. When you look at who's holding her, we talked to her mother. So her mother has been raped 3 times. When she was 14, she was raped for the first time, and she's got a little girl as a result of that rape. A number of years later, she was gang raped by 10 men. A month ago, she was raped by another man. As a result of the first rape, she's got a child who she's not bonded with. As a result of the second rape, she's HIV positive. As a result of the third rape, she's now using meth. And so we look further, so we delve a little bit further to see what other support sits in this family, because now we need to sort out not only the child, but we need to sort out the mom. So who's going to hold the 2 of them? So now we look at Granny, who luckily we called in. And Granny, unfortunately, has had a husband who also raped. And was domestic violence becomes violence against children. He was violent not only towards the grandmother, he was violent towards his children. And we're starting to see early signs of violence of the mother against her 14-year-old, probably unresolved issues in terms of bearing that child from the rape incident. So what I'm trying to say is, and we're going to get to it later, I'm not going to take all the time, is don't stop referring, don't stop looking. Children are really being traumatized in ways beyond what we could even imagine.
Okay, deep breath. Okay. But it gives you a sense also of what the child protection team is carrying collectively on our behalf. And the thin red line in the sense that they So when should you report? You should report in terms of the Children's Act if you conclude on reasonable grounds that a child has been abused in a manner causing physical injury, has been sexually abused, or deliberately neglected. So this is mandatory reporting requirements. And then in terms of the Sexual Offences Act, you report if you have knowledge of a sexual offence committed against a child. Form 22 of the Children's Act provides a range of different indicators that give you a sense of what that abuse neglect might look like. A more detailed list is outlined in Regulation 35. And in a sense, when you come to that reasonable conclusion, you are drawing on a series of those different indicators to come to a professional judgment. But you can also report voluntarily under the Children's Act. Any person, not just a health professional or an educator or a social worker. If you believe on reasonable grounds that a child is in need of care and protection. And again, you would fill in that Form 22, and the intent of the Form 22 is to trigger the social work investigation. So that someone is going out and ensuring that that child is okay, that that child is safe. So it doesn't mean you have to be 100% sure. It means that you need to be able to trust that niggling doubt, that gut instinct, and act on it in children's best interests. And the Act, Section 150 of the Act, defines children in need of care and protection much more broadly than the narrow definition of abuse and neglect. So it's important that each one of you knows this range of indicators and recognizes your responsibility to speak up and to report. Who should you report to? Under the Children's Act, you have the choice to report either to a designated child protection organisation, the Department of Social Development, or the police. Whereas under the Sexual Offences Act, you have to report to the police to trigger a criminal justice investigation. How to report, we've already talked about reporting under the Children's Act through the Form 22, and the Sexual Offences Act would report directly to the police and use a J88. It's also important to recognise that failure to report has consequences. This is part of your legal mandate as health professionals to step up and to report rather than to look the other way. But reporting is, in a sense, a little too late, right? The damage has been done. And so what I would like to call on you as a department, or us as a society to do, is to step in far early and to invest more in prevention. Because we know it's not only better to prevent violence before it starts, but it's also cheaper. The costs to the child, to the family, to society are less if we get prevention right. So Carla is going to speak a little bit to some of the early warning signs that should wake us up and trigger some kind of early intervention.
So, you know, when you're sitting in your, I just want to say at S11, at the moment, we've got a wonderful group of doctors that is they're such nuisances at the door of social work. But they've picked up on such valuable potential dangers for children. And although I'm not looking for more work for my department, I want to say, don't turn away from the small risk factors. Tony always used to say that look upstream, and it's in the primary health care system, but it's also right here. You know, when a mother is unbooked in a pregnancy, when she hasn't registered a child, when she hasn't taken a child for immunizations, you may think, in the scheme of things, I can fix it, okay? And you can, if you address it, and you recognize it, and you interact with that mom. And yes, it does take more time. But I'll tell tell you now, it will leave you with a better feeling. It's better for your own well-being to do your work at a little bit of a slower pace. But it's also going to rescue that child. Because failing to pick that up down the line, you're going to find the child fall into other risk factors. So suddenly now you're going to find there's problems with the child's weight, the child's not growing, and we need to now involve the dietitian. Suddenly now the parent at the beginning is not going to take a month to get a birth certificate, but going to take a year. Or the parent is going to carry on the child's going to carry on with a different caretaker. The next time you see that child's no longer with the mother. The child comes in with the grandmother. How many of you can honestly say that you ask, who is this lady or this man with this child? Many people don't. They just assume if it's a woman, it's the mother. You need to ask, because there's so many children that are in alternative care, and alternative care is a risk. It's an indication that the child's been at risk already, and that is why the child needed to go into alternative care. So there are many risk factors that you can, disability is a risk factor. You can't just assume that the mother sitting in front of you is going to always care well for her child. And why it's important what Jane said in terms of looking after the family, because even that mother will tire. It's not easy. I'm sure if I ask you, I'm sure if I ask you, getting up at night and checking those machines, it's not easy. You can easily become despondent. Doing your gastrostomy, you love that child, but how? It's a nuisance for you to get up and check on things, or just do it's a schlep to how much preparation you need before you feed that child. So, it's important to see disability as it's a risk factor in a child, and you've got to pour more into that family, and you've got to ask more to see if that child's not at risk. Very young parents is another thing. Some young parents are wonderful at parenting, but some of them are not. Some of them are not seeking help. Some of them are not turning to their support systems or to the older generation. And often we get the young parent. Just in last week we had a 16-year-old young girl who definitely was not coping to care for a child. We've got another young girl not on methamphetamine, on what drug is she on? Well, anyway, on drugs, and she's been on that drug since she's 14 years old. Multi-generational trauma, just the example I spoke to you beforehand. How is that mother who's been raped thrice, grandmother who's been exposed to domestic violence and beaten for all her life, how is she going to support the child? Behavioral problems coming up in a child. Last year we had a child that came into the hospital where the child was diagnosed as having ADHD, and you know how quickly people diagnose that. What we weren't looking at is the fact that that child had been badly beaten by his family.
Thank you. So just to recognize that you need to look carefully, look deeply, and respond and refer, and put support systems in place. Here the intent is to support, not to trigger a criminal investigation. So it's particularly important to help both families and children to cope with stress, for us as a department to help one another cope with stress, and to recognize that stress is driven by a series of different kinds of stresses, some small, some major. The physical, the psychological, and environmental stresses build on one another and can push families to breaking point. We also know that a little bit of stress is a good thing. It's exciting, it's invigorating, it keeps us awake and alert. But too much stress, prolonged stress, starts to become overwhelming. And at a certain point, it can flood the system and, in a sense, shut us down. So many of the women that you might see out in Kulani with severely malnourished children, you can see the maternal depression that they're carrying. They are carrying too much. They can no longer step up and engage and support and interact warmly with their children. Sorry. And just to recognize that when that stress persists for too long, it starts to become what we call toxic stress. If you look at the literature, that includes malnutrition, it includes poverty, it includes violence, neglect, maternal depression. And those three things interfere with the caregiver's capacity to care, but also the child's development and its ability to relate, its ability to learn. And so the nurturing care framework that's been adopted internationally is pushing us to engage, to recognize that the one protective factor in the space is a responsive caregiver, someone who steps in, who listens to the crying baby, who picks the baby up, who comforts them, who feeds them, because that shifts the cycle. And it allows the baby to trust, it allows the baby to feel confident, to go out, to explore, to learn, and it builds healthy relationships. And so for the very first time, we find that the World Health Organization, together with the National Department of Health, are talking not just about healthcare, they're talking about love. They're talking about relatedness and relationships. And so, building on that foundation, we would like to invite you as a department, as individuals, to have a heart and to have the courage and the confidence to reach out, to recognize the child in front of you, to ask those questions, to listen to children and mothers and to take them seriously, to listen to that gut response that you might have and then to act on it. And just to say that that action needs to happen right the way across the curve, from providing easy access to sexual and reproductive health care services for women so that they can choose when to have children, to actively supporting parents and caregivers, promoting non-violent forms of discipline, listening to children, recognizing and responding to those very early warning signs that we've talked about, reporting abuse and neglect, but more importantly than anything else, once we've seen those children, enabling them to heal. So this is the beginning of a campaign. We would like to invite you, all of you as departments and individuals, to take with you one of the posters, one of the pledges, and as a department for us to step up and to promise to stand up for children and to protect them from this. Thank you.
Thank you for always flying that patient advocacy flag. We really appreciate you grabbing a lot of us and running along with you. Carla, thanks to you and your department, and thank you for looking after yourselves as well. This is really heavy work.
Just say one thing. We've got these posters that we'd like every department to take one. With that poster, it gives you something to talk about in your department as to how things are going to change up in your department. How you're going to look at things differently where children are treated in your team. We'd like you to even make a commitment. This is a pledge of promise. And we're not saying Red Cross and all our employees doesn't have a heart. We think you've got a great heart and we think you try very hard. But we wanted to have something that's going to remind you of doing it every day, because we all fall into a time where we don't have enough time, where we become complacent, where we I just want us to know that things are looking so bad for our children at the moment. I think that's why Tony's standing outside with that placard, stop the war on our children. I'd really like us to put this up at the law of every department. We're even sending one, we've got management's approval. We're sending one up to Dr. Beth Engelbrecht and King Tutti, and today putting one up. And if you want to sign your name in the heart, own it. Own this heart and own your promise. Thank you. Great.
invitation for people to go and do a silent protest outside the front of the hospital, I think is what you were suggesting, Laurie. But at least take one of these to your department and put it up there and burn it. And thank you to the audience and thank you for listening to your patients. Go and have a great day.